Dr. Pearlz clinical rounds here with the case on acute otitis media. Let's get right into it. 10-year-old male with no past medical history and no known drug allergies presents with the complaint of left-sided moderate ear pain for the past 3 days. Patient reports fever of 101 since this morning. Patient reports having a runny nose, nasal congestion, and cough for 3 days before the onset of ear pain. Patient denies recent swimming or cotton swab use. Patient has tried taking ibuprofen with some relief. Upon review of systems, patient denies hearing loss, tinnitus, dizziness, otorrhea, chills, and sore throat. Common symptoms of AOM may include ear pain, otorrhea, irritability, fever, anorexia, and muffled hearing. Vital sign is significant for a temperature of 100.4. Exam of the left ear is significant for bulging of the tympanic membrane with erythema and pus with the loss of light reflex. TM is intact. Canal is clear without otorrhea, erythema, or edema on both sides. Evaluating the ear. When evaluating the ear, first inspect the outer ear. Begin with the normal ear if the pain is one-sided. Palpate the mastoid process for any tenderness. Look for erythema, edema, discharge, or vesicles on the outer ear. Gently palpate the tragus and pull on the pinna as pain may indicate acute otitis externa. Gently insert the ear speculum and inspect the canal for otorrhea, edema, and erythema. If there is evidence of cerumen impaction and TM cannot be visualized, gently perform oral toilet to remove the cerumen. Inspect all 4 quadrants of the TM for bulging, effusion, perforation, otorrhea, redness, or white or pale yellow color. When bulging of the TM is noted, this indicates middle ear effusion and inflammation. If there is no bulging and the presence of effusion cannot be confirmed, pneumatic otoscopy may be used to confirm middle ear effusion. This may cause discomfort, so avoid this exam if bulging is present. Based on the presentation and exam, patient has an acute otitis media. So what is acute otitis media? Acute otitis media is an acute infectious process affecting the middle ear, which commonly occurs due to an impairment of the eustachian tube function, which prevents drainage of secretions from the middle ear space. This can be precipitated by an acute upper respiratory infection or seasonal allergic rhinitis. AOM occurs more often in children, and common bacterial causes include Streptococcus pneumoniae, non-typal Haemophilus influenzae, and Moraxella catarrhalis. Other causes such as Staphylococcus aureus is uncommon in children but is seen more often in adults. Viruses and bacteria may cause co-infection. Common viral causes include rhinovirus and RSV. How do you diagnose AOM? As per the American Academy of Pediatrics, to diagnose AOM in children, you need moderate to severe bulging of the tympanic membrane or a new onset of otorrhea not due to acute otitis externa. AOM can also be diagnosed when there is mild bulging of the TM and recent, less than 48 hours onset of ear pain evidenced by holding, tugging, rubbing of the ear in a nonverbal child, or intense erythema of the tympanic membrane. AOM should not be diagnosed if middle ear effusion is not present, based on pneumatic otoscopy and/or tympanometry. If there is no sign of inflammation, such as redness, bulging, white-yellow discoloration of the TM, pus, purulent otorrhea, ear pain, tugging, rubbing, fever, and only effusion is present in the TM, this is an otitis media with effusion. OME is not due to a bacterial infectious process, and typically, air fluid level or bubbles may be visualized. Fluid will appear clear, and the color of the TM will appear gray, amber, or blue. Antibiotics are not recommended for OME. What is the treatment of AOM in children? Pain should be managed with ibuprofen or acetaminophen. A scheduled regimen will likely provide better pain control than on an as-needed basis. Antibiotic treatment should be prescribed for children 6 months and older with severe signs and symptoms, such as moderate or severe otalgia or Italgia for at least 48 hours or temperature of 102.2, and children 6 to 23 months of age with bilateral AOM without severe signs or symptoms, such as mild Italgia for less than 48 hours and temperature less than 102.2. Treatment duration is 10 days for children under 2 years of age. For young and older children with non-severe unilateral AOM, either antibiotic or observation can be recommended. If observation is recommended, follow-up should be ensured in 48 to 72 hours, and if there is no improvement or symptoms worsen, antibiotic treatment should be initiated. A wait-and-see method with an antibiotic prescription may also be recommended. Treatment duration is 5 to 7 days for children 2 years of age and older. The treatment of choice is amoxicillin as long as the child has not received amoxicillin within the past 30 days, or the child does not have concurrent purulent conjunctivitis, or does not have a penicillin allergy. Recurrent history of AOM with treatment failures to amoxicillin is another reason to avoid amoxicillin. Concurrent conjunctivitis with AOM is called otitis conjunctivitis or conjunctivitis otitis syndrome, and is usually due to non-typable Haemophilus influenzae and should be covered with additional beta-lactamase coverage with amoxicillin clavulanate. Topical ophthalmic antibiotic drops are not necessary. Alternatives to penicillin antibiotics include cephalosporins. Ceftenir, cefuroxime, or cefpodoxime oral preparations, or ceftriaxone IM or IV may be used if the penicillin allergy is a non-type 1 reaction. Ceftriaxone may be given as a one-time dose or once a day for 2 to 3 days. If the patient has a type 1 penicillin allergy, azithromycin, clarithromycin, and clindamycin may be used. What do you do if there is recurrence or treatment failure? If there is recurrence or treatment failure and amoxicillin was initially used, amoxicillin clavulanate can be used instead. If an antibiotic other than amoxicillin was used, ceftriaxone can be considered. What is the treatment of AOM in adults? Amoxicillin clavulanate is a first-line treatment. If amoxicillin clavulanate cannot be used, amoxicillin can be used instead. If there is a history of a non-type 1 penicillin allergy, cephalosporins such as ceftenir, cefpodoxime, cefuroxime, or ceftriaxone can be used. If the penicillin allergy is anaphylaxis, azithromycin, clarithromycin, or doxycycline can be used. Mild to moderate infections can be treated for 5 to 7 days, and severe symptoms can be treated for 10 days. So how do you manage treatment failures in adults? If the initial antibiotic was amoxicillin clavulanate, cephalosporins such as ceftenir, cefpodoxime, cefuroxime, or ceftriaxone, or levofloxacin can be used. If there is evidence of TM rupture, an oral antibiotic should be used. Topical antibiotic without ototoxicity, such as ofloxacin or ciprofloxacin, can be added. The patient needs to follow up with an ENT. What are some potential complications of AOM? Mastoiditis, petrositis, meningitis, brain abscess, epidural abscess, hearing loss, facial nerve palsy, labyrinthitis may occur. Suspicions for these conditions require evaluation and management by an ENT or in the inpatient setting. Our patient is a 10-year-old male who has an acute otitis media of the left ear. Patient has no known drug allergies and amoxicillin should be prescribed. Ibuprofen is recommended for pain and fever. Patient is advised to follow up if there is no improvement in 48 to 72 hours for re-evaluation. Follow-up. Patient should be advised to follow up in 48 to 72 hours if the symptoms are worsening or not improving. For patients who are following observation, follow-up should be scheduled in 48 to 72 hours to decide antibiotic initiation. Patients who have recurrent AOM, such as 3 episodes in 6 months or 4 episodes in 1 year, with 1 episode in the preceding 6 months, or hearing loss, signs of severe AOM, or tympanic membrane rupture, should be referred to an ENT for further follow-up and management. That's all for today. Thank you for watching. If you enjoyed the video, please hit the like and subscribe button. Let's move on to the next case.